This is Dr. Amna. I was discussing about the endometrial hyperplasia. I was discussing how should a woman with atypical hyperplasia not undergoing hysterectomy be followed up. So these are the women who refuse to undergo surgery, or they are not fit for surgery, or they do not want surgery for any other reason. So we will always counsel the patient that you are having atypical hyperplasia. There are chances that there is cancer and endometrial cancer along with atypical hyperplasia in 43% of cases. So if patient still refuse that she does not want and she understands she has mental capacity and she understands the complications and what does it mean of not undergoing hysterectomy with this condition, then we will do the hysteroscopy to rule out whether she is having cancer along right now. If there is no cancer, then we can do the routine endometrial surveillance in this patient. We can manage this patient like with the LNGIUS and along with the or progesterone. And now we have three negative. We will do the endometrial surveillance after 3 months, and if it turns out negative, we have seen regression, and that then again and after 3 months we call her and these are having negative. So we were able to obtain two consecutive negative biopsies. So how we will do this endometrial surveillance for the rest of her life. So in asymptomatic women with a uterus and evidence of histological disease regression based upon a minimum of two consecutive negative endometrial biopsy, long-term follow-up with endometrial biopsy every 6 to 12 months is recommended until hysterectomy is performed. So next is HRT and endometrial hyperplasia. So sometime when patient present with the endometrial bleeding, abnormal uterine bleeding, and she comes and we do all the examination as I have told, history examination and everything. And in the history, we identify that patient is having hormone replacement therapy. First of all, we know that the systemic estrogen only HRT should not be used in women with the uterus. So, and when we give the patient HRT, we consult the patient that she will come for after 3 months for review, and if she's having any um, concerning problem, any abnormal uterine bleeding, she should come anytime. So then after 3 months, if patient is normal and no problem, then we will call the patient after 1 year. This is a management of follow-up of the woman who is been given HRT. So in the course of taking HRT, she is experiencing abnormal uterine bleeding, and she came to us and we do complete examination and we did endometrial sampling, and it shows that she patient is having endometrial hyperplasia. So we will manage the endometrial hyperplasia, but we should not forget that she is having a risk factor. So for HRT, what should we do? So we will give the patient, we will manage the patient as the type of endometrial hyperplasia. Like if she has having without ATPR, then we will again give the option of observation, LNGIUS, progesterone, but we will try to manage this HRT as well, because this is the contributing factor. So management will be same, but what should we do in relation to HRT? So women with endometrial hyperplasia taking a sequential HRT preparation who wish to continue HRT should be advised to change to continuous progesterone intake using the LNGIUS or continuous combined HRT preparation. All women taking HRT should report any unscheduled vaginal bleeding promptly and be referred for further investigation. Stopping sequential combined HRT may be sufficient to induce regression of endometrial hyperplasia. So we can, first of all, we can send the patient for the review that whether she needs HRT or not, or whether she can stop this HRT, or if she wants to have HRT, we can stop the sequential HRT and we can ask her to take continuous combined HRT and treat hyperplasia with progesterone or hysterectomy, whichever is required according to type of hyperplasia. But if she's having a endometrial hyperplasia with ATPR, then obviously we will go for hysterectomy in this patient. How should endometrial hyperplasia be managed in women on adjuvant treatment for breast cancer? So this is very sensitive point, because this is discussed in exam, in the written exam, and in the part 3 exam as well. So a woman is having history of breast cancer, and breast cancer, she has been treated, and now she is taking tamoxifen. Now, with tamoxifen, it's very interesting that tamoxifen has antagonist actions on the breast and the agonist action on the endometrium. So it regresses breast cancer, but it increase the chances of endometrial cancer. So women taking tamoxifen should be informed about the increased risk of developing endometrial hyperplasia and cancer. So first when a doctor oncologist prescribe tamoxifen to the patient, they consult the patient that there are chances that you can have endometrial hyperplasia and cancer, and you should report any abnormal vaginal bleeding or discharge promptly. Patient is already having the knowledge that she can develop this complication. So there are for the adjuvant therapy, there are multiple options, like one is tamoxifen, and other options are anastrozole, exemestane, and letrozole. These aromatase inhibitors are also used for the adjuvant therapy, but these aromatase inhibitors does not increase the risk of endometrial hyperplasia and cancer. So question is that if aromatase inhibitor are good for the breast cancer and they does not increase the endometrial cancer, why we don't use it regularly? So there are smaller studies are being conducted up till now. So they are lacking data about the safety of these drugs. So this is the limitation for these medication. And for the tamoxifen, we know it's good for the breast cancer, but it has negative effect on the endometrium. So tamoxifen is a selective estrogen receptor modulator. This is also question for part 1 as well. That inhibits proliferation of breast cancer by competitive antagonism at estrogen receptor. And however, it has a partial agonist action on other tissues, including the vagina and the uterus. This estrogenic effect may promote the development of fibroid, endometrial polyp, hyperplasia, and increase the risk of endometrial cancer. The risk increases with both dose and duration of treatment. For longer duration you take tamoxifen, the more chances you will develop endometrial hyperplasia. The ability of tamoxifen to induce endometrial cancer and other pathologies vary between pre and postmenopausal women. Okay, now there is a question if tamoxifen was endometrial hyperplasia. So, and it's very good for the breast cancer. So can we give progesterone therapy prophylactically in these patients? We can give LNGIUS to prevent polyp formation, and that it reduces the incidence of endometrial hyperplasia in women on tamoxifen. There is evidence, but the effect of the LNGIUS on the breast cancer recurrence risk remains uncertain. So its routine use cannot be recommended. So how should women who develop endometrial hyperplasia while on tamoxifen treatment for breast cancer be managed? The need for tamoxifen should be reassessed. The management should be according to histological classification of endometrial hyperplasia and in conjunction with the women's oncologist. So with the management, this patient management, we will involve oncologist as well, multidisciplinary approach. And we will manage the hyperplasia according to standard recommendation, but we will also discuss the need for tamoxifen for future. How should endometrial hyperplasia confined to an endometrial polyp be managed? So there are also cases in which they have seen that there's a polyp and they remove the polyp, did the polypectomy, and then they see that there is endometrial hyperplasia in the polyp. They have seen endometrial hyperplasia in the polyp. So that's why it's very important to remove the polyp by hysteroscopy. When you remove when you remove the polyp, and you can see there are chances that there is background endometrial hyperplasia with the polyp. So you remove the polyp, you visualize rest of the endometrium, and you take sample. So complete removal of uterine polyp. If when you do the histology of polyp and background endometrium, and you see that only there is endometrial hyperplasia on the polyp. Then complete removal of the uterine polyp is recommended, and endometrial biopsy should be obtained to sample the background endometrium. Women with atypical hyperplasia in a polyp were slightly more likely to have hyperplasia in the surrounding endometrium than those with the hyperplasia without atypia. In the absence of background endometrial hyperplasia, it seems reasonable to assume that removal of the polyp may be curative. So if there is any endometrial hyperplasia in background endometrium, then subsequent management should be according to histological classification of endometrial hyperplasia. So this is the algorithm which is at the end of this guideline. This is all I have explained. So I will tell that algorithm for the management of endometrial hyperplasia. This is the endometrial hyperplasia without atypia. And then when patient is having endometrial hyperplasia without atypia, then we will address risk factor, and options are observation, LNGIUS, and oral progestogen. Risk factor, we know tamoxifen, HRT, obesity. Then we will, then observation can be done, LNGIUS and oral progestogen, second line. So if a patient is having atypia, without atypia, then endometrial biopsy will be done after 6 months. And if we see after 6 months that there's a regression, then we will do two negative, another call for another 6 months. And if another 6 months, it shows that there is no two negative biopsies have been taken, then we will discharge the patient. But if patient is taken and oral progestogen or her BMI is more than 35, we will monitor the patient annually for the rest of her life. So on the other side, there is the atypical hyperplasia, and its treatment is total hysterectomy plus BSO. But if a patient fertility required or surgery contraindicated, then endometrial biopsy, we will do the treatment, this one, LNGIUS or oral progestogen, and do the endometrial biopsy after 3 months. So after 3 months, we will say if it regress, then we will again, we will do with the fertility, it's different because with the fertility, if comes one, after we do the endometrial biopsy after 3 months, if comes negative, we will refer for the fertility specialist, and we will ask her that she can have assisted reproductive technique, and she will conceive, and then we will do the 6 to 12 monthly follow-up in this patient until hysterectomy has been done. But you never forget, here's the point, that fertility requiring or surgery and contraindicated, here is a long list of investigation and counseling. When patient does not want hysterectomy right now, and you give her the medical treatment between these two steps, you will want to thoroughly take history and examination and do the hysteroscopy and TVS and tumor markers and MRI to rule out any coexisting pathology, endometrial cancer. And if there is any cyst, ovarian cyst is seen on TVS, then we will do CT scan as well. So if in the treatment there is a persistence of the symptom, then we will do hysterectomy as well. And in the postmenopausal we always do hysterectomy with BSO, and if premenopausal, we will discuss the need of removal of ovaries, but tubes are always removed. So if there is a progression, then total hysterectomy plus minus BSO managed according to local cancer guideline. If there is progression, then obviously it has become cancer. So these are the all of recommendations. If there is any more question you think that I did not explain, kindly write in comments.